Thank you for coming this morning. I appreciate the opportunity to give you guys a talk. So what is plastic surgery? It's a little hard to define. We are one of the few surgical specialists that operates from head to toe in all age groups. We're not constricted to one single organ system. And it's a very rapidly expanding field which has created all these additional subspecialties with the advent of new innovative techniques. Plastic surgery itself is derived from the word plastikos, which is Greek, meaning to mold or to shape. But the majority of the procedures we do actually don't even do that, so even the name itself is confusing. And just as an aside, this was actually a Jeopardy question not too long ago, so if you find yourself in Jeopardy, now you know the answer. Of course, if you ask the public, what is plastic surgery, what do they do? This is what they think of. Cosmetic surgery, and it's widely publicized through the popular media that that's what the plastic surgery does, so they don't have a good understanding either. And so when you're talking with your patients, especially the families, about, oh, you need to go see a plastic surgeon, they might be wondering why. And while cosmetic and aesthetic surgery is certainly a large part of plastic surgery, it's really only half of the puzzle. Really, plastic surgery evolved from its roots in Reconstruction, unfortunately out of wartime, but led to massive innovation. As the problem we're fixing becomes more and more complicated, the reconstructive side of plastic surgery and the cosmetic side of plastic surgery tend to blur more together. Perfect example, facial reconstruction. After all, the function of the face is at least partially to look like a face. And so a good reconstructive operation has aesthetics in mind. I think the best description of what plastic surgery is was given to me by one of my mentors, a very famous plastic surgeon, Dr. Vasquez, who said that plastic surgery is a problem-solving specialty through the application of its principles. We don't just put in tiny sutures, we don't just make scars look good, we solve problems. So with that in mind, I'll talk a little bit about general pediatric plastic surgery. And I sat down and just thought about the things that I see routinely in my clinic that you, thankfully, are sending to me. And that includes lumps and bumps, wounds, scars, to a lesser degree minor burns, patients suffering from Macromastia as well as Gynecomastia, and we'll touch on all of these. So lumps and bumps, or as one of my mentors affectionately called hickeys, these include cysts, lipomas, dermoids, pilomatrixomas, and various nevi. I think it's important for the families to understand that they don't all have to be removed. We're happy to counsel the families about the indications for removal and the benefits and risks of removing them, but in general, a lot of these can be observed and they do not require surgery. I've shown some examples here of probably the most common things that I take care of being dermoid cysts that happen commonly around the brow. Usually, if it is laterally based like this, it does not require additional imaging. It's a question that always comes up. It's really only the lesions that are in the midline in the glabellar region that we need to image to rule out for intracranial extension. That's a surprise you do not want to have in the operating room without knowing and being able to prepare for it ahead of time. The other common cyst that I take care of is a pilomatrixoma, which has usually this very kind of bluish, purplish discoloration of the overlying skin. It's very firm in appearance, and the textbooks say that it usually derives after some kind of trauma to the skin, whether it be a fall, a bug bite, a cut, although the vast majority of the families, when I ask them if they can think of any incidents or sentinel event that caused this, they can't really recall anything. As far as nevi go, probably the most common thing that I see are nevus sebaceous, especially on the scalp, because it leads to alopecia. All of these are non-cancerous. All of these can be observed. Caveat is that nevus sebaceous do, in a very small percentage, have the ability to deteriorate into a basal cell carcinoma, so they should at least be closely followed. But the real reason we're usually removing these is to deal with the bald spot on the top of the child's head. The dermoids and the pilomatrixomas do not degenerate into cancer. They can be observed. They do not tend to go away without surgery. And they can, in rare instances, become infected, which if they do is a good indication to go ahead and remove them. Which brings up the whole question of when do we remove these? And so there was a bulletin posted by the FDA in 2016 to talk about the risks of general anesthesia in pregnant women, and more importantly, for what we're talking about, young children under the age of 3. And this is still the official stance of the FDA that general anesthesia should be carefully considered weighing the risks and benefits in children under the age of 3. I find that deferring surgery, elective surgery, until that age is a little excessive, and after close discussion with my anesthesia colleagues and my experience through training, I think 12 months of age is a reasonable alternative. That being said, this is the official stance, and we have to discuss this, our anesthesia colleagues discuss this every time that they talk with the patient that are going to surgery, but it's a heavily controversial and studied topic. And I believe that there's some new data coming out recently in relation to hernia surgery that may alter this threshold age of 3 that we're talking about right now. That being said, when I do see a young child that has one of the previous lumps or bumps that we were talking about under the age of 12 months, I say, let's wait, we'll take care of it once the kid gets a little bit older just to make it as safe as possible for the kid. So wounds, these are subcategorized into acute versus chronic wounds. Acute wounds are generally the result of some type of trauma. If you see that initially, send them to ED, call us. They're always better treated early on to be washout to avoid infection, and the aesthetic outcome of repair in the early phase is always better than in delayed healing. So that's pretty straightforward. Chronic wounds is a different story. These can occur either through an acute wound that was allowed to heal in a delayed fashion, or a pressure sore from a patient with cerebral palsy, et cetera, et cetera. These never require urgent referral, but they should be referred to a wound care center, which we have. These can be reconstructed to fully eliminate the wound for the patient, but it has to be done very carefully and very thoughtfully. There's a lot of medical optimization that goes in prior to surgery as far as nutrition, making sure that they have all the appropriate resources following surgery, as well as making sure that we've optimized all of their medical comorbidities. Because the truth of the matter is, patients who develop pressure sores are at risk of redeveloping pressure sores, and they only have a very limited number of operations in their lifetime that we can use to reconstruct these. And so we need to be very thoughtful about when we employ those techniques to make sure that we're not burning bridges prematurely that they may ultimately need later on in life. Scars. Everyone always asks about scars, and I think it's important for families to understand that any injury deeper than the epidermis is going to leave a scar of some fashion. I tell folks this is plastic surgery. It's not magic surgery, unfortunately. We can't do surgery without scars. There are techniques that we use to try to minimize how conspicuous those scars are, but they will definitely be there. And the way I explain to my families is that how that scar ultimately turns out is about 50% of what I do in the operating room, is 25% of the child's genetics and just how they heal, and then 25% of things that we do for scar care following surgery. These are things that you can employ in your own practice if you see children with scars, and they include very simple things like scar massage that helps soften the scar, as well as application of silicone sheeting or silicone-containing products in addition to sun protection. Scars, even in darker pigmented individuals, are very prone to becoming burned, and if they do, it can permanently pigment that, which is very, very difficult to fix short of revision. With regards to silicone, these products are widely available over the counter at the drugstore, through Amazon. We don't know exactly why silicone helps scars, but we hypothesize that it probably increases the hydration of the scar tissue, which both softens and flattens the scar. Best employed within the first year or so of the scar forming. It's difficult sometimes to get good results with this in children because it does require a prolonged period of basically continuous use unless bathing. So in order to really have the benefit of silicone sheeting, unless the kid's bathing, they need to be wearing one of these silicone sheets or using the silicone stick on top of the scar. As you are well aware, kids love to pull stuff off, including this. But it is an available resource that the families can use if they're diligent. This is one of my passions, and I co-run the breast clinic with another one of my partners, is treating patients with large pendulous breast, especially in the adolescent population. It's been well proven the benefits of breast reduction surgery in the adult population as far as improving quality of life. We've run into issues as we've started to increase our ability to treat younger and younger patients, with insurance companies feeling that it's not really indicated in the younger population because they're still growing. I agree with that comment. I don't want to be operating on children that are still growing, and therefore we have a threshold of a minimum age of at least 16 before doing breast reduction surgery. But I do think that it can greatly improve the quality of life for these patients. They suffer from chronic back pain, chronic neck pain, and a trigo underneath the breast and chest skin that can cause recurrent infections. And there's a real opportunity if the young woman has finished growing for us to intervene at an early age and improve these so that she can go and do the things that she's not been able to do, whether it be exercise, dance, sports, et cetera, et cetera. It's really important, though, that we try to minimize the risks of complications following surgery. And so we work with a multidisciplinary team in order to do that, to get them to an ideal body weight that's sustainable, make sure that they're not around smokers. Hopefully they're not smoking either, which greatly increases the wound healing complications. And again, make sure that they have, to the best of our ability to predict, finished their growth patterns. Questions that we're commonly asked, that you may be asked if you're referring a patient to us about a breast reduction surgery, are listed there on the right. Usually the patient, but the mother will ask, well, how does this affect my daughter's ability to breastfeed in the future? This has been heavily researched, and basically what we found is that patients that have a breast reduction surgery are able to breastfeed at the same rate as people that have not had breast reduction surgery. So we extrapolate that to mean that it probably does not ultimately affect a woman's ability to breastfeed. Not all women can breastfeed for various reasons, but if they're able to breastfeed before, they should be able to breastfeed after. What it may impact is their ability to fully supplement their infant through breast milk alone, and they may have to give some additional formula if they're not able to produce a large enough quantity. Another common question, how does this affect my breast cancer risk? Well, it probably, at least in theory, reduces it. We're removing tissue that could degenerate into breast cancer. Not a good reason to have a breast reduction, but that's probably the short answer. What it does increase, though, is the risk of that patient requiring a biopsy in the future. It can be sometimes very difficult for the screening radiologist looking at mammograms to differentiate between scar tissue from the breast reduction surgery that patient's had versus a concerning microcalcification that requires a biopsy. The vast majority of times, these come back as negative, but they are at increased risk of having a biopsy recommended over their lifetime once they start the screening process. Another common question, what about nipple sensation? It's very common to have reduced nipple sensation immediately after surgery. Fortunately, this comes back within the first year or so afterwards, but it is permanent and 10%, and so a consideration that we always talk about with the patients when we see them in clinic. On the flip side, what about adolescent boys that develop excess chest tissue or gynecomastia? It's a pretty common problem, and some studies estimate this happens in upwards of 50% of boys, with a majority of it actually regressing as they complete growth and through the pubertal period. And so for this reason, we are very conservative on the patients that we do intervene on. It is important, though, to make sure that there isn't a modifiable factor or a concerning factor that's driving this. Fortunately, most uncommonly, but very important to catch, would be a testicular tumor, as well as hormonal imbalances or drugs that contribute to this. And we are always careful to screen for these. Some people routinely send folks to endocrinology to have this worked up ahead of time. I find that not a good use of resources. I send this panel of tests, and if any of that comes back abnormal, I'll have the endocrinologist evaluate them. But I don't think it's necessary to routinely send them to endocrinology first. Obviously, if they're taking any potentially offending drugs and they can be switched to something else, that's advisable, and to see how they respond. But gynecomastia is different in adolescent boys than macromastia is in females because the scar burden is always going to be front and center. And it can be quite severe sometimes in these surgeries, depending on the degree of gynecomastia that you're treating. In the most severe cases, we have to do essentially a subcutaneous mastectomy on the chest tissue of the boy, and then do a free nipple graft. We remove the nipple entirely as a postage stamp and put it into the right spot. The nipple will never have sensation. It never looks the same. And as you can see, and these, I would argue that this is a very good outcome. These scars are always there. And so it's important that the patients and the families understand the scar burden before we embark on a surgery, because they're not going to be leaving the operating room and immediately going to the swim club and not having everyone wonder what happened. So with regards to specialty plastic surgery, as I mentioned, because it is such a diverse field, we have several different subspecialty areas. I'm going to touch on cleft and craniofacial because that's my passion, what my expertise is in. But this is something just to be aware of, that if you do see a patient that might benefit from one of these other areas, they're probably best addressed in that subspecialty clinic. Our schedulers are trained to help screen for this so we can get patients to the right spot. It can be very frustrating for families if they end up in the wrong clinic. We do our best to try to avoid that, but just something to be aware of. So cleft patients. I love cleft surgery probably for a lot of the same reasons that you guys like being pediatricians, because we get the opportunity to follow our patients from birth until they actually go away to college, which is fantastic. We always like to try to see our mothers even before the baby is born so we can counsel them, reassure them, explain, we know that this could be an issue that we have to deal with, but we know how to do it. This is the plan. You don't worry about the cleft. You worry about enjoying your baby. We're going to take care of the problem for you. And so that's always, I think, the best way to go about things. We have a multidisciplinary team involving both ourselves as plastic surgeons, ENT, our orthodontic colleagues, speech-language pathologists, genetics, as well as neuropsychologists that all help to intervene on this child throughout their life as they come back to see us. Early childhood after they're born is all about feeding. That's what we counsel the family on. We provide them resources on how to feed their infant. It's pretty common that the child is not going to be able to breastfeed if they have a cleft palate. They just can't form appropriate suction, and so they're not going to be able to latch. With a cleft lip, it's variable. With a cleft palate, that's pretty much universal. We do see with some commonality that infants that are born at outside centers that are not comfortable dealing with clefts very quickly go to place an NG tube to feed these infants, which is usually not necessary. And one of the reasons we like visiting with the mothers ahead of time, because they usually can feed out of a bottle, admittedly a modified bottle, but a bottle nonetheless, and avoid that NG tube to make sure they gain weight. That being said, we want to make sure that they are gaining weight because it's one of the criteria that we use to decide when they're ready to get their cleft lip repair. And so we keep very close tabs on them as well as work closely with you guys to make sure that they are gaining weight and that we can intervene and make adjustments as necessary if that's not actually the case. So this is kind of the timeline that I go over with families that present to me with a cleft. Hopefully, again, we're seeing them in the prenatal period so we can kind of counsel them. Then the earliest decision that we have to make is whether or not they benefit from something that's called NAM, or nasal alveolar molding. I'll show you that in a second and explain the benefits for that. First surgery they get is the cleft lip, usually not before 3 months of age, followed by the cleft palate at about 12 months of age. And then we wait to see how that palate's working. The reason we repair the palate is not for feeding, it's for speech. Babies and children are very savvy. They will figure out how to eat just fine whether or not we repair that cleft palate, but they will not be able to talk normally if the palate is not repaired. We try to time our surgery so that we can do it at a safe time for the infant, but before they actually start talking so they don't learn bad habits that then have to be unlearned once the anatomy of the palate is corrected for them to be able to talk normally. If that turns out to not be the case, we may need to do some residual revision surgeries later on in life. But usually they get a bit of a break until they get to be about 7 to 9 years of age, and we do a bone graft at the cleft of the gum for the adult teeth to come in. The teeth won't come into empty space. They need bone to be there, and the bone needs a tooth to be there in order to stay. So we have to very carefully time this to when those adult teeth are coming in, specifically the canine, and we do that with x-rays along with our orthodontic colleagues. Then they usually get another break from surgery until they grow, or at least finish growing, and we do any adjustments of the jaw and/or revisions to the nose later in life as they're getting ready to go away to college, which is, again, just a real joy for us to be able to take care of these kids over the first 18 years or so of their life. So this is what NAM does for us. This is an infant shortly after birth, a very wide cleft, severe flattening of the cleft nose, shortening the columella, and you can't see it on this two-dimensional photograph, but there is severe displacement of the alveolar tissues in an anterior-posterior direction. This makes it much more difficult to fix in the operating room. So when we're able to take advantage of NAM, it's really helpful for us. And I think if you show this picture to any cleft surgeon, they would much rather fix this cleft than that cleft. It just makes it an easier operation for us and decreases the chances of having complications. That being said, we do have the ability to fix clefts no matter how wide they are. This is an example of a patient that I took care of that got to us late in life because they were bouncing around foster care. He was almost 2 and still never had his cleft lip or his palate repaired, and so was not really able to benefit from NAM preoperatively. We can still get a reasonable result, but this is definitely a child that we would put NAM on had the opportunity to early in life. So early referral to us, we have the chance to evaluate whether or not they benefit from that and talk to the family is always advisable. Craniofacial surgery. So I get lots of referrals for abnormal head shape as well as for ear anomalies. We'll talk about both of those. So this is always the question. You've got flattening on the back of the head, right? Is this craniosynostosis? Is this positional plagiocephaly? Anyone take a guess which one is which? It's actually not entirely a fair question, showing you just these two photos, and I'll explain why in a second. What you really need to see is this posterior view of the child. So this is an example of lambdoid craniosynostosis, where there is an infusion of the left lambdoid suture. And the reason I know that, and the reason why you guys will now know that, is because anytime you have that, there is inferior displacement of the ipsilateral ear. People used to talk about looking at the ears in relation to anterior and posterior displacement as far as differentiating this, but that has turned out to actually be somewhat variable, whereas you always have this presentation with lambdoid craniosynostosis. This child suffers from positional plagiocephaly and does have kind of the classic stigmata of anterior displacement of the ipsilateral side of flattening. So again, when you have lambdoid craniosynostosis, you have inferior displacement of the affected ear. You have bulging on the contralateral side, versus a child that just has positional plagiocephaly will not have any of that cranial base tilt, and they'll have bulging on the same side as the flattening. So if you suspect craniosynostosis, when do you send them to us? I would urge you to send them to us as soon as possible. The reason is that we do, in some select cases, have the opportunity to intervene early in life through more minimally invasive operations to correct it. Not all synostosis lend themselves to this. I don't expect you guys to differentiate that, but if we don't see them until later in life, we've already missed the opportunity to do that less invasive procedure. So if you ever have a doubt, go ahead and see us. Surgery will sometimes happen as early as 2 months of age, but can happen at any time. And in more severe cases, like this child that had a unicoronal craniosynostosis that we didn't get to until about 3 years of age, we employ new techniques using vertical surgical planning to help design what the eventual cranium is going to look like, which has really enhanced our ability to treat these more complicated deformities more efficiently with less operative time, less blood loss, and better results overall for the children postoperatively. In a child that you suspect positional plagiocephaly, there is an opportunity to intervene on these children with molding helmet therapy. Not every child requires a helmet, and we would make sure that there aren't things that are contributing to the positional plagiocephaly that we need to address first. Usually, most commonly, not doing enough tummy time, or in more, in unfortunately rarer cases, torticollis that's requiring the child to keep the head position that way or the other. If you do suspect that, early referral to physical therapy to start working on neck range of motion and strengthening of those muscles is definitely indicated prior to any other interventions. In kids that do have moderate to severe positional plagiocephaly, though, there is an opportunity to help improve head shape with a molding helmet. It's best done usually between 4 to 9 months of age. It takes advantage of that exponential period of brain growth that the child undergoes during that period of time to really push the bones in the right direction. The helmet doesn't really pinch the head, it just kind of dictates where the bones are allowed to grow. And so we require the brain to really push and be the driving force of where those bones end up. This clinic is actually run through our neurosurgery clinic, which we work with closely. But again, it's ideal to try to get them in sooner rather than later because it optimizes our chances of getting a good outcome, and it's really hard to fix once they get too much past 12 months of age. The helmeting companies will advocate that they can fix this 18 months, 24 months out. I would argue that they have a bit of a conflict of interest. In my experience, I just have not found it to be the case, so early referral, I think, is always ideal. Another common thing that I see, ear anomalies. And this is something that also, I think, benefits from early referral. We have an excellent opportunity to fix these without surgery through molding, but it requires taking advantage of the circulating maternal estrogens in order to do that. And those go away after about 4 weeks or so. You might lengthen that a little bit if the infant is breastfeeding, but not by much. And so the earlier we get these kids, the better. And if we get too far out, we may have missed the boat, which may mean that the kid requires a surgery later on in life. There are a lot of children, though, that I see that are sent for consideration molding therapy that the molding therapy doesn't really benefit. What it really helps a lot is when there's distortion of the antihelix of the ear and you lose this kind of very gentle C shape, as well as very prominent ears. It's not uncommon to have what I just call newborn ear, where there's just kind of redundancy of the skin over the helix itself. But if the underlying structure of that helix is normal, as it grows, it will pull the skin with it, and the molding doesn't work on the skin, it works on the cartilage, so it's not going to really benefit that. But again, if you suspect that a child might benefit from molding therapy, you should call your plastic surgeon sooner than later. This is an example of a commercially available device called the Earwell. It's what most parents often come in requesting. I use this in select cases. It is not covered by insurance, and it is somewhat costly, so I try to reserve it for more severe cases. I've actually been able to obtain pretty good results using some dental molding compound and just some tape at much reduced cost to the families. But they may ask you about the Earwell, and if they do, this is what they're talking about. It's an adhesive device that goes around the ear, and then it has a bunch of different components, a contrabowl conformer, these helical conformers, and there's actually a posterior sulcus conformer that goes behind the ear to help shape everything, which in severe cases, if you need it, you need it, but a lot of times it can be addressed without. The other thing that we get asked about are children that have very prominent ears that maybe miss the boat on molding therapy early in life. This becomes a bit of a dual question about what's the right time to operate on these children. We don't want to operate too early because doing so will introduce scar tissue into the ear that can cause growth restriction. And so we wait until the child is at least 5 or 6 years old. The ear is at least 85% of the way grown at that point in time, and so we've found that you can safely operate on the ear without causing growth restriction from the ensuing scar tissue. But what I find to be the more commonly limiting factor on doing these surgeries is the maturity of the child. Because doing surgery like this, the most common complication is recurrence of the prominent ear deformity, and it really requires a period of activity restrictions and dressing care postoperatively to minimize that risk. And if the child is not going to be compliant with that, it's worth waiting until they are. And so I would say more commonly, we're doing these surgeries when the child is 8 or 9 or even later in life for that reason. I really rely on the families to help guide when they think that that's an appropriate time for their child. So in summary, if you think you need a plastic surgeon, we're here to help. We don't just do cosmetic surgery. We address all kinds of problems for you. We really focus on improving function and the subsequent quality of life of the patient with our operations. And generally, we can be consulted in an elective fashion to address most of these problems for you. But we're really reliant on a close partnership with our pediatricians to work together to make sure that we're getting our patients in at an appropriate time to take care of them, as well as follow them afterwards, and also help advise us if they may not be fit for surgery. This being wintertime, we have a lot of children that are sick for various reasons, and it's really worth waiting until they recover from these illnesses before undergoing an elective procedure. So if you do have a patient that has an upcoming surgery within a week or two that comes to your office before an upper respiratory tract infection or whatever else, at a minimum, please advise the family to call us, or even better yet, give us a call to let us know, and we'll get in touch with the family to say, hey, let's wait for your child to get over this. It's just not worth the increased anesthesia risk. Thank you very much.